Hi everyone, today our debate and presentation is going to be on our topic, which is collaboration with other professionals. To begin, we can look at the table of contents. First, we'll introduce our group members. We'll then go over the history and the relevance of this topic. We'll also discuss what it means to collaborate with other professionals. We'll then go into our 3 points and counterpoints on this topic. We'll then follow that with some common questions and answers, and then finally with a conclusion. So to put a name to the face, my name is Emily Halcomb and I'll be doing the introduction. We also have Liv, who will discuss the visuals. Luis will help summarize some of these topics. Mary is going to go over the questions and answers at the end, and then Devana is going to go over the research. So to begin, autism spectrum disorder, or ASD, continues to be one of the most prevalent childhood disorders. With this being said, there are many individuals who come together to support and comprise the treatment team that help this individual with ASD. This can be board-certified behavior analysts, or BCBAs, speech-language pathologists, or SLPs, occupational therapists, special educators, clinical psychologists, and medical doctors. All of these individuals and more comprise of a large interprofessional treatment team that collaborate and work together to improve health and educational outcomes for individuals with ASD. It's important to look at the relevant data with this topic. So children with ASD are reported with unmet needs for home health care and mental health services, 25% for physical, occupational, or speech therapy, 13% for a specialist doctor, 29% for drug addiction or treatment counseling, and then 26% for substance abuse and treatment services. The likelihood of parents reporting at least one unmet need for specialty services was 1.86 times higher for parents whose children did not have access to family-centered care. To continue, youth with ASD only obtained acceptable healthcare transition services in 14.9% of cases. 33.3% of parents of ASD-affected children with a history of elopement, which is wandering, claim to have ever sought advice from a medical expert regarding elopement behavior. So what does this mean, and why is our topic, which is collaborating with other professionals, important? So as we see, there are large quantities of individuals with ASD and families who care for an individual with ASD who have unmet needs. So collaborating among other professionals will assist these families by uniting the strengths and competencies of individuals, specialists, to maximize client outcomes. This collaboration can also lead to enhanced program and problem solving, increased efficiency, and access to additional resources. Finally, this collaboration will lead to an increase of treatment integrity and better maintenance of acquired skills.
So for topic number 1, which is training, the important points are the importance of providing an evidence-based training to support staff in the field of ABA. Staff such as RBTs need to be trained in an evidence-based training that focuses on performance skills and not just verbal skills. This is the best way to train staff because we work in an evidence-based field, and the approach should be similar with our training in order to get the best results when working in implementing procedures for our clients. This helps staff be more accurate and efficient when implementing treatments, which makes our data a lot more accurate in order for our behavioral analysts to work with.
All right, here is a table from an article, Evidence-Based Staff Training, a Guide for Practitioners by Parsons and Rolisan. Over here on to the left, we have a training action plan, and it's broken down in layman's terms. So this training protocol for conducting a training session using behavioral skills training with a group of new hire staff working towards being a registered behavior therapist. Simple training steps are broken down in layman's terms for easy guidance. And this has been proven to be effective in the workplace, the 6-step action plan. So the next slide will go over the results from this action plan. On this slide, you see table 2, which is just the difference between baseline accuracy and post-training accuracy for errorless prompting and signing. The significance of talking about these tables and this way of training is because a lot of ABA centers do utilize this type of evidence-based staff training. And when used correctly and efficiently, staff can improve their quality of training and therefore improves the quality of services that our learners are receiving.
So the counterpoint for training for topic number 1, there are many support staff and human service agencies that do not obtain the necessary skills needed to implement essential ABA protocols. Although the training of support individuals is necessary, if it is done inappropriately, it could lead to ineffective behavior therapy. Notably, training that is done without evidence-based approaches has not been proven to be effective.
The capability of a behavior analyst to conduct behavioral skills training, also known as BST, is a vital skill set. BST is a teaching method that is widely used in ABA to train staff, parents, and caregivers involved with a client's therapy. Without this skill set, successful staff training is not probable to be effective. There are 2 main components of BST that make this evidence-based procedure effective for training. Performance and competency-based training are those 2 valuable components of BST. Being experienced in the application of a behavior change plan alone is not enough to successfully implement an entire behavior change procedure. The performance element of BST consists of the trainer demonstrating the targeted behavior skill and the trainees being able to model that exact same behavior skill. The competency element of BST involves the trainer consistently training the trainee until the trainer believes the trainee can perform the targeted behavior skills sufficiently. Ineffective training lacks the 2 major elements of BST, performance and competency. The risks to ineffective training include stagnant progression in a client's therapy, injury to a client and/or support staff, regression in a client's therapy, and removal from associated therapies.
As previously mentioned, the risks to ineffective training include stagnant progression in a client's therapy. There are a couple of other risks involved with inefficient training, which is injury to a client or support staff, regression in therapy. And so with this model, it is complex and intense, and it takes time. And if the ABA field is constantly trying to keep staff in the door, the resources provided to these companies aren't being allocated appropriately to maintain a well-oiled machine at all times for our learners. So this could be a huge downfall to training in ABA and what the right method of training should look like.
So for topic number 2, we will be talking about collaboration with occupational therapist or OT. Some individuals with autism spectrum disorder have skill deficits in daily living activities and routines. For example, dressing, toileting, feeding, and self-hygiene. This is something that an OT focuses on, and they help individuals acquire the skills necessary to become active participants in their own daily living. Board-certified behavior analysts often break down daily living routines into what is known as tasks analysis. So OTs and BCBAs have common ground in this area. OTs can provide proper training on how to teach daily living skills, and BCBAs can incorporate these skills into their learners' comprehensive treatment plan. This is how both OT and BCBAs can collaborate together to help individuals with autism spectrum disorder.
Collaboration between occupational therapists and board-certified behavior analysts in the ABA field have a common overarching goal to improve services for their learners through evidence-based practice. OT is one of the most common outside therapy services that individuals with ASD participate in. Bridging the gap by teaching OT-based skills such as fine motor repertoire, gross motor exploratory play, and self-care in a setting where reinforcement is prominent and frequent. So think about it. Your learner, your child, your niece, your nephew is receiving ABA therapy, but they're also able to get OT therapy, but all throughout the day intermittently in the natural environment as it's occurring. So this is why OT and ABA need to come together and collaborate to make the best therapy for our stakeholders. And here are some visuals to help guide what we mean by this point of collaboration in OT and ABA. The main point in this left visual says that effective teamwork must include a common purpose. And as mentioned, OT and ABA share that same common purpose, and it's to improve daily living and leisure skills for our population and our communities. So these steps over here on the right, they're just like golden rules of collaboration, and these rules basically state that when followed, you have a solid collaborative foundation. Going off of the previous point, OT goals can be taught using the ABA model of mass practice and reinforcement strategies. Both fields encompass the same end goal for their stakeholders. An example of these key skills are listed down here. So both OT and ABA really work on academics. An OT could teach proper pincer grasp for writing, wrist orientation for fitting puzzle pieces or cutting with scissors, knowing how to model a craft when given on a board. Also, both fields can collaborate on communication, so isolating a pointer finger to use a speech device or a pincer grasp to pull a picture for a picture exchange. Self-care skills such as toileting, feeding, dressing, leisure time, all tasks that we use in the clinic with task analyses, OTs are teaching these skills. Motor skills and social skills, so gross motor play, strengthening core muscles, and then encouraging our learners to engage in meaningful interactions. And the best part about this model is that it is all intertwined, and in the ABA setting, it can be done in the most natural environment possible. Hopefully, it's encouraging that so that it can be generalized across all environments. And here is yet another supporting visual as to why BCBAs and OTs should be collaborating more than they are now. Although, OT is the most common outside service for our learners in the ABA field, it could be incorporated into their ABA therapy, which just means more opportunities for reinforcement, encouraging an increase in those behaviors, but also allowing them to occur naturally as they navigate through the clinic.
So for the counterpoint for topic number 3, we will be discussing common barriers to collaboration between occupational therapists and BCBAs or people in ABA to develop comprehensive treatments. These include misperceptions of other disciplines and evidence-based practice or EBP, This is where ABA has stressed the use of evidence-based practice from the beginning, whereas OT practitioners aren't as focused around the direct use of evidence-based practice. Another one is the differences in terminology between the two different fields. The two different fields contrast between the methods of evaluating progress, being held to different professional and ethical standards. They have different codes in their ethical standards and lack of knowledge in the other field. The unprofessional behavior, ABA, is often misunderstood as other fields view ABA as solely discrete trial training. Other impressions of the ABA field include failing to consider plans for generalization.
Successful collaboration is defined as comprehending the values, activities, and knowledge that is recommended by a divergent practice or professional. The values, activities, and knowledge should involve the contribution of knowledge from each professional involved. Additionally, both parties should share an equal responsibility in making communal decisions for the quality of treatment for their client. When there is not an equal share of responsibility in the decision-making, treatment can be ineffective, quality of life can diminish for the client, and there can be unnecessary obstacles to accomplish acquisition targets. Furthermore, the misperception on the use of evidence-based practices greatly affects the collaboration between occupational therapists and behavior analysts. This is mainly due to the differences in how evidence-based practices are defined in their prospective board associations and due to the fairly new movement to follow evidence-based practices in the field of occupational therapy. But despite some differences, they still have a major common belief of evidence-based practices being based on a combination of research results, clinical judgment, and client cultural practices.
Here we have a couple of visuals for the counterpoint on collaboration with occupational therapists and professionals in the ABA field. There are a multitude of misconceptions between EBM and EBP. EBM stands for evidence-based medicine, whereas EBP is evidence-based practice. However, the fields both of the OT and ABA field, they do not follow the same codes or the same evidence-based practices. So there tends to be confusion, fallout, lack of terminology, or unknowns of terminology between fields. So it can make collaboration frustrating, especially when these professionals spend so much time really learning the information related to their own profession.
For topic number 3, we will be discussing telehealth. And then telehealth is an important tool used in many fields to communicate important health information and provide health services virtually in their homes. In ABA, this proves to be a useful technological tool that allows ABA service providers to assist those clients unable to make it to an ABA clinic or are in an area where ABA services are not closely available. This is very important because telehealth is known to have very good efficacy. ABA through telehealth is comparable to in-person services, allowing clients to receive the treatment and quality service they expect and deserve. This is all important, especially when in times like the pandemic, which allows treatment and parent training to continue even when in-person service is not available.
With the recent pandemic and lack of access to behavioral health services, such as applied behavior analysis, many researchers have begun to format telehealth service models. These telehealth service models represent technological guides on how to successfully establish ABA telehealth training curriculum for parents, BCBAs, registered behavioral therapists in clinics. In a study done by Pollard in 2017, they concluded that in order to make telehealth the most beneficial and effective, standard protocols for clinical infrastructure should be established. The protocols would consist of concordant clinical standards for program implementation plans and procedures to ensure high quality and ethical services. Additionally, the telehealth protocols should also come with manuals to universally inform the therapists, parents, clinics, and BCBAs on how to create a learning environment or space that is therapeutically beneficial to the client. This would also include coordinating a place within the space for the telehealth technology. When designating a space, the stakeholders involved would have to take into account an optical area for the camera and safety protocols for a client that engages in aggressive or self-injurious behaviors. Moreover, in order to optimize the technology, a solid internet connection has to be connected, and troubleshooting counter strategies have to be formulated. Furthermore, when the listed standards and procedures are taken into account, telehealth has been proven to bridge the gap of access to behavioral health care between urban and rural populations.
This figure here is from another research article that is cited in the previous slide. It is just the flow chart for decision making between telehealth and in-person / in-home consulting. It's easy to follow with numerical data. There's a number of meetings required. So this just helps board certified behavior analysts navigate a more efficient consult and reach more families in the area.
So the counterpoint for telehealth in topic number 3 is that telehealth needs to be a viable option for the client. For example, they need to have good internet, and sometimes the culture or the way they are brought up doesn't involve a lot of technological use. It must make sense to implement the use of telehealth for that particular family that you're working with. If the family does not have the knowledge of how to use technology or the resources like computer or signal, then telehealth might not be the best option for the family. We also assess the severity of the case because telehealth might not be viable if the behaviors are severe, which could require on-site crisis management. All these can make parent training, treatment, and working with other professionals on meetings very difficult.
Beneficence and non-maleficence, 2 core ethical principles of the American Psychological Association, includes protecting the consumer and taking care to do no harm. When determining appropriate clients, a clinician is responsible for identifying whether the resources are available to effectively implement the behavior intervention via a telehealth service delivery model. Such considerations may include the client's age and severity of challenging behavior, as well as the systems of support within the family and the surrounding community. The provider and organization must determine whether they have the clinical support staff on site and within the organization via telehealth to provide safe and effective treatment. It may also be clinically necessary to provide additional oversight of the on-site staff and have a crisis management team in place to assist the on-site team as needed. It is also important to determine whether the technical resources are available and sufficient to provide the services. For example, the family must have access to a reliable internet connection with sufficient bandwidth for real-time video streaming, as well as computer or tablet with a webcam. If a family does not have internet, a Wi-Fi enabled device or mobile hotspot can be purchased by the provider or family. With the poverty rate being higher in rural communities compared to urban communities, providers may encounter this barrier more frequently than other communities. and therefore will need to determine if they will provide the internet access and accompanying technology for the families.
The map here depicts the downfall of telehealth in the United States. So you can see on this map, it is going to highlight in dark blue the percent by county that has access to or subscription to a broadband service. So you can see in the tan areas, it's quite like rural, away from the cities. They don't have a subscription to a broadband service, making it near impossible for them to be able to consult virtually with a board-certified behavior analyst. And this is the biggest downfall to technology in this field today.
We are now going to move on to some frequently asked questions. We conducted multiple interviews with BCBAs as well as researched some information, and this is what the responses were. Question 1. What is our responsibility to a client when their caregivers are recommending a treatment that does not line up with our ethical code? One BCBA stated it is our responsibility to suggest a method that are evidence-based and support the family through objective data. If a family is set on a treatment that does not align with ABA, as long as it is not harmful to the client, we should continue to provide objective behavioral data with a phase change line showing the treatment, though we should not be the ones implementing such said treatment. We can provide alternative suggestions that are evidence-based to achieve a similar goal. Another BCBA stated, our code states our first responsibility is to our client and advocating for appropriate services, codes 3.01 and 3.12. We should advocate for them and provide the caregivers with our clinical recommended treatments, which are evidence-based. We should try to help the caregivers understand the research. If it is something they are asking us to implement, we would need to inform them we are unable to implement protocols that aren't evidence-based and do not align with our ethics code. We can, however, offer to collect data before, during, and after the treatment, but only if the treatment doesn't interfere with ours and isn't dangerous. If it is something that would seem to reach mandated reporter level, then we would need to report it immediately. Question 2. How have ongoing current events impacted the way you collaborate with other professionals? Is COVID still a relevant topic when trying to meet with other professionals? During the height of COVID, the world of ABA had to make some drastic changes. We went from implementing strategies in person with our clients to trying to do the same process behind a screen, hoping that our client was fully attending or just staying within the room. In 2020, there was an article published called Advocacy, Collaboration, and Intervention, a model of long-distance special education support services amid COVID-19, which addressed this very concern. Due to the fact that once schools closed to help decrease the spread of COVID-19, this as well stopped services for those that have disabilities, since the education system is not required to continue services due to this form of event. What had to take place was BCBAs that were employed by both the school district and NPA, a non-public, non-secretarian agency, had to gain the approval of the school district administrators to be able to perform open-ended interviews with the parents of their school clients. They needed to provide evidence or data that these students required some form of support at home, whether it is from a registered behavior tech, parent training, pre-recorded or live video modeling, printed material, or even a social support group. Once this did get approved, BCBAs then had to virtually meet with a team of individuals, including those from the NPA, district level administrators, county and state level offices of education, in order to make this collaboration happen fast and effectively. One of the BCBAs we interviewed stated, COVID is not a relevant topic within her collaboration process at this moment. Everything states to be getting back to normal in the sense of in-person meetings. The collaboration process has steered away from virtual meetings as well as virtual trainings. An additional BCBA stated, COVID has not affected collaboration over the past year. In fact, the current events and the way of the world has come to ABA and the field is shifting to more trauma-informed care as well as more compassionate care. It is moving away from older treatments of ignoring the client, pushing the client to perform a task, following through with the client, etc., and is evolved to better treatments that are still just as effective and have research to support this. The shift in the field has created a divide, and there are many practitioners who still hold true to the old methods. This doesn't necessarily affect collaboration, as you don't tend to collaborate with other BCBAs on a case, but it will affect where you choose to work. If the company doesn't align with your values and which direction you have chosen in the field, you may want to switch new jobs. Question 3. When performing staff trainings with teachers, SLPs, and OTs, is the process collaborative or deterring? One BCBA interviewee stated, ideally, this is a collaborative process. This can be difficult depending on what school of thought the teachers, SLPs, or OTs come from. She has worked with some who agree with ABA and understand behavior. This has been very helpful and made the collaborative process more smooth, which in turn tends to lead the client to more success. SLPs can help with communication deficits and teachers with skill acquisition. When collaborating with OTs, it is helpful if they are on the same page, but it can interfere with behavior decrease if they are working on sensory regulation. And lastly, question number 4. As a BCBA and clinical manager, does the collaboration differ in any way from when you switch job sites? One BCBA said, collaboration can be different when you are working with colleagues at a clinic site versus in a community or school setting when you have to collaborate with teachers, daycare workers, etc. And both you need to build rapport with who you will be collaborating with, work with them, and always operate with the client's best interest in mind. This can be easier in the clinic site as there are colleagues and tend to be easier to build a rapport with. However, in different settings, you are entering someone else's classroom or workspace. You need to respect this and work within the confines of the setting while also maintaining clinical integrity. The best way to do this is to build rapport with the people in that site.